Students, today we'll be learning about the hand, one of the most complex machine made ever so far. So I'll be following these objectives. First, we'll be looking at the functional components of the hand. Then we'll be engaged with identifying these bones of the hand on the given x-rays. Then we'll be learning about the intrinsic muscles of the hand, their attachment, their functions, and their nerve supplies, and their close association with the extrinsic muscles of my upper limb. Then we'll be learning about the sensory and the motor distribution of my peripheral nerves which are coming to my hand, and then we'll be looking into the formation of my superficial and deep palmar arches and their areas of supplies through different digital branches. And the last but not the least, we'll try to establish some of the clinical correlates with these normal structures of the hand. When we look at the hand is an ultimate operative tool of upper limb, and it is capable of what? Prehensile and manipulative function. So what are these? And we have two principal grips for its prehensile functions, and these grips are a power grip. I'm sure everybody knows what is a power. And the second thing is precision, and precision is the delicacy, the fineness of your grip. So these two things are possible in same shot, and that we'll be establishing at the end of this presentation. There is a little activity which helps you to understand how is this power and precision are closely associated. There's a variety of combination of these two primary grips, and we'll be looking into these things, and these are possible because we have dorsal digital expansion, and we can see that extensor hood, how it is associated for this type of movements. Now, the power grip, we all know the primary function of your hold, you want to hold your bat, your racket, or any other thing in your life, and the precision and the muscles are extrinsics. For the power, primarily who's coming in play are my extrinsic muscles, and for precision we are using, and what are the precision activities? Precision grip is associated with different arts: threading a needle, sewing, suturing, threading, painting, drawing, writing, playing fine instruments. All these are precisions, and who are instrumental? My intrinsic muscles. And these intrinsic muscles, we will be learning them in different categories. We have intraossei and lumbricals, and they are having different groups of them that we'll be learning today. Now, you're looking at this hand. What I'm trying to show you, is it a clinical anomaly, or is there some nerve damage? No, we are looking at my hand has three functional components. And what are these? So this is my central fixed component. Who's contributing here? We'll be just looking at shortly at the end of the slide. And then on the radial side, we have a radial mobile component, and definitely on the ulnar side, we have an ulnar mobile component. So all these components, how they are making my hand a functional component. So these are the thumb, index finger, and the mobile finger together. My thumb and the index finger, they work together, and this coordination is making radial digital tripod. So my mobile ulnar component is termed ulnar hook, and that provide for stable power grip with palm or in a hook grip. And my pinky is an important for power grip, whereas thumb is important for both power and precision. So this is how we'll see the interchange of all these different components, the functional components of the hand. We are not going into the structural things. Primarily, our main focus will be on the functional components of the hand. So now let's review. We have learned this content before, and we know we are looking at a digit, but this is not my first digit. What is the difference between my first digit and from digit 2 to digit 5? My first digit has only 2 phalanges, but my digit 2, 3, 4 and 5, they have 3. Let's label it We are looking at metacarpals, proximal, middle, and distal phalanx. And then this is the palmar view, and that is on the dorsal view. We can see this brown. This is my extensor digitorum tendon, and primarily it's coming up, and how it's been stabilized with my digits. We can see that this gray structure, that is called my extensor hood. And this extensor hood or dorsal digital expansion, its main job is to stabilize, and it is used for different intrinsic muscle attachments, and they are bringing the different precision activities. And now on the palmar aspect, we are looking at the tendon of flexor digitorum profundus. Why I'm saying this is profundus? Because we can see that it's attached at the base of my distal phalanx, and then it's been overridden by my flexor digitorum superficialis. If you focus at this point, when it reaches here at the base of my second or the middle phalanx, it splits, and one end goes on the one side and the other end goes on the other side, so that it can give way to the tendon of my flexor digitorum profundus. And this is how the organization. Now both these tendons, as they are closely associated with each other and they are used, they are mobile units, so to minimize the friction, they are being sleeved in a structure that is known as my flexor synovial sheath. And the word synovial is not new for you, and that is connected to that there is a kind of lubrication which has been embedded there. And how we need to fix that flexor synovial sheath, we want him in its position, so there are certain bands which keep it connected to the digit where it has been dedicated, along with the tendons which are embedded inside, and these are named as the annular and the cruciforms. Okay, so one very important aspect, if you are trying to break a flower, there are fair enough chance there are thorns, and they might puncture the tip of your needle. If this needle, if this sharp thing prick your tip of your finger, any of your digit, there is chance of receiving an infection. You never know what is being coated on this tip, on this sharp needle-like structure. So the infection, if it involves your synovial sheath, we call it synovitis, and if it involves only your tendon, we call it tendinitis, and together they are known as tenosynovitis or tendosynovitis. And remember, these infections are not only localized within the synovial sheath, they may traverse up and they can go to the forearm. There are certain spaces. We have talked about those spaces already. So now let's look at the dorsal digital expansion. We have talked about it before. So that the main job is it has to stabilize my extensor digitorum tendon, and it is also served for the attachment, for the very precise movements, for the attachment of my intrinsic muscles, and they are my interossei and the lumbricals. And now let's look at that. My metacarpal, then my proximal phalanx, middle phalanx, and distal phalanx. And then they are making joints. We need to know these names. My metacarpophalangeal joint. Then in between my proximal and the middle phalanx, we have proximal interphalangeal joint, and between my middle and the distal phalanx, we have distal interphalangeal joint. Guys, you need to know the names of these joints because they are very instrumental when we will be talking about different intrinsic movements, different movements which are connected to my precision. So now the power, as we have already discussed, the power is dependent on the extrinsic muscles, and this extrinsic muscle we have already discussed. This is one of the extensor digitorum. What is its job? When there is a contraction of my extensor digitorum, my hand from a fist position, it goes open, and then this tendon is stabilized by dorsal digital expansion. And now look at the long extrinsic tendons of my flexor compartment, and this is profundus and this is superficialis. And same, you can see the tendon of my profundus passes in between the splitted tendon of my flexor digitorum superficialis, and they are stabilized, and when we contract these muscles, what we have achieved, we are going towards flexion, and this ultimately leads to a fist formation. So a powerful flexion of the digit is dependent on the movement of my flexor digitorum superficialis and flexor digitorum profundus, and on contrast, the powerful extension of my digits is dependent on the extensor digitorum muscle tendons. So this concept needs to be very, very important. Now, this was regarding the power. Now let's talk about the precision. For precision, we are provided with a very special unit. You can see that this muscle is coming from my metacarpal bone, and it's going where? To the dorsal digital expansion. So it's not going to a bone. And who's this muscle? This is my intraossei. And we don't have one intraossei, we have intraossei both on palmar side as well as we have intraossei on the dorsal side. So, and we label them as the dorsal intraossei and the palmar intraossei. And they are 4 plus 4. And then there is another muscle. What's that? It's coming from the tendon of my flexor digitorum profundus, and it is also going to my dorsal digital expansion. So it's not going to a bone, it's from a tendon to an expansion. And who's that? This is another very important muscle. If you look at its appearance, it looks like a worm, and on the basis of that, it's been labeled as the lumbricals. The lumbrical word is in Latin is called the worm-like. So this muscle is like a worm, and that goes from the tendon of my flexor digitorum profundus to the dorsal digital expansion, and it is responsible for very specific type of movements. And look at the axis of the movement at the metacarpophalangeal joint. And now guys, this is a real important line. Never forget that the intraossei and the lumbrical muscles, they act through, you can see that they are attached to the extensor hood, and they cross, they are going anterior to my metacarpal phalangeal joint axis and posterior to my proximal interphalangeal and distal interphalangeal joint axes. And so now what it does, they create flexion of my metacarpal joints and extension of my interphalangeal joints. This is important, and you need to understand, because there is a crossover between the flexors and the extensors. So these muscles are very precise in bringing the two actions, flexion as well as extension. You need to spend time in learning this concept. I use the term movement, the Tata hand. This is a little bit advanced, but just remember, delete this line here, as in the movement of the hand. So precision movement, what movement? The precise movements. And this is how these intrinsic muscles are really instrumental. So now this is the flexion, we are doing this, extension is occurring here. So you can see that how, so this muscle brings flexion here but extension on these movements, and this is what the interchange of the different axes. Now thumb is the most integral part of human hand, and thumb, when we have to understand the movements of the thumb, we need to look at how my hand is placed and what is the axis of the movement, and then only you can understand. If you try to mix the two things and if you change the axis of the movement, then you will be confused. So now thumb lies where? In the plane. It's roughly at the right angle to the plane of the remaining digits. So its movements are different from those of the fingers. The fingers are doing what? They are primarily performing extension and flexion. But thumbs are different. So the movements of the thumb, what they are capable of doing, along with flexion and extension, they are doing abduction, adduction, opposition and circumduction. And remember, circumduction is a combination. It's not an individual movement, it's a combination of different movements. Now let's look at how the flexion is being performed. So just do your hand like this, opt your hand like this, and see this arrow indicates the act of flexion, and then look at the extension. So it's just the reverse. Here we are decreasing the angle, here we are increasing the angle. I'm sure you have learned this concept in foundation. And now look at the adduction. So this is a plane, the axis has been changed, and now this is what? This is the adduction, and when you are taking away, this is the abduction. Guys, you can fairly confuse between these two, so you need to practice this stuff. Otherwise, you can be confused. And then opposition, where my two extreme digits, digit 1 and digit 5, they are facing each other. That is called opposition. Are we good with this? So now opposition of the thumb is a complex movement, and that includes what? A combinations of my abduction, medial rotation and flexion in the sequence. And opposition is a fundamental movement of all my grasping functions of the hand. So opposition is really important, and that makes my thumb its role. It has a big role to play. Now let's label this. This is, I'm sure it will be easy. We are good with these. The radius ulna. You know what we are saying? There are around 27 bones who come in play in making my hand. So the scaphoid, one of the carpal bone, the most fracture bone out of all these carpal bones. Then the other names, and what is famous about this lunate? It is the most dislocated bone in the, if you find any dislocations in the carpal bones, the number one concept which should be coming to your mind, that should be about the lunate bone. So now these are my carpal bones, and now we can see there is a joint which has been made here, and this joint is my radiocarpal joint. And now these are my metacarpals, my proximal, middle and the distal phalanges. And then the joint between the metacarpal and the phalanges, we call it carpo-metacarpal joint. We talked about metacarpophalangeal, interphalangeal and distal interphalangeal joints. Now let's look the same stuff on the given X-ray. So there is an X-ray of a hand. That was right, this is left. Always X-rays has to be labeled to give you the direction which hand you are looking at. Now you might have a question, is it a palmar view or a dorsal view? So let's look at that. But these are the cues, these are the points. Look at this, these bones. They are really instrumental in identifying the things. Pisiform and the hook of the hamate, they are real guides for our learning. So now the trapezium, trapezoid, capitate, scaphoid. Look at its close association with my distal radius. So when we have a fracture at the wrist joint, the scaphoid fracture is quite common. And this one, remember, never forget, in the middle, which is closely associated with my distal radius, that's nothing but my lunate. And this is my hamate, and look at its hook. Tricutrium, pisiform. So try to differentiate pisiform, hamate, hook of the hamate. So that shows we are looking at the palmar view of a human hand. And this is my most dislocated carpal bone, that is a lunate, most fractured carpal bone, that is a scaphoid. These are the key points, never forget them. Now you are looking at the metacarpals, base and the head. Now my P1, P2, P3. What is this P1, P2, P3? Proximal, middle and distal phalanges. Same base and the head. And this, look at my first digit. That's worth knowing. You can differentiate. There is 1, 2 and 3, but there is only 1 and 2. So we don't have a middle segment, proximal and distal phalanges. And now look at, what is this? This is something additional. Have you learned about this? No, maybe. What do you think? This is my sesamoid bone. So sesamoid bone is not really a true bone. This is something which is a production of a friction. We can have so many locations, but patella we talked about because that was most common and always there. This can be there, this may not be there. Now let's go back to the drawing and let's make the skeletal framework of a human hand, and we are still on the left side. So preaxial, lateral and postaxial medial. You remember in the beginning of MSK when I was giving you an intro to the limb development, we talked about these things. And I'm sure in your upcoming lectures of developmental anatomy, you'll be explained in detail about these. So now let's label them by first digit, second, third, fourth and fifth digits. The first digit, the thumb, is famous with the name of pollex. Anything going to that is pollex, pollices. And we have learned so many names of the muscles. Indicis, my index finger; medius, my middle finger; annularis, where you put ring, that is your ring finger; and the pinky, little finger. And now this yellow dotted line is the main axis. And then we are looking at the carpal bones, metacarpals, and then we are looking at the phalanges. And we all know P1, P2, P3, and we know that base, like the thumb has only 2 phalanges, not 3. So now we are looking at a joint between my radial distal radius and my scaphoid and lunate, that is my radiocarpal joint. And there we can see carpometacarpal joint. And what is this? Between the metacarpal and the proximal phalanges. So metacarpophalangeal joint, we have proximal phalangio-interphalangeal joint and distal interphalangeal joint. So we have proximal interphalangeal joint and we have distal interphalangeal joints. Now let's put at the ligaments. If you don't remember these names, it's okay. We have a series of ligaments. Now this is a must know thing. This blue structure is my, you can see by its splitted pattern at the base of my second phalanx, that's my flexor digitorum superficialis. And then you can see this brown thing which is going through that, and that is nothing but my flexor digitorum profundus. And now can you see this bridge like thing which is going at the base of my hand, and that is my palmar carpometacarpal ligament, and then there will be a palmar metacarpal ligament. And then now let's build a human hand from this scratch, from the bones, from the ligaments, and we'll keep on building. We'll put muscles, arteries and nerves in a layer wise pattern until we cover this whole hand with the skin. You need to be very careful in watching. Every structure will be coming and labeled. I might use lines to show you the labels, or I might use the color matching, will be helpful for you for your understanding. Now let's make it. So there I am showing you some muscles, and these muscles, you can see that they are in between my first and second digit, second and third digit, and look at the pattern, they are coming in different direction. Guys, you are looking at interossei muscles, and these are on both the sides. Because of this picture is not a 3D, so I cannot show you all 4. Maybe I can show you 3 on one side and 4 on other side, but actually they are 3, both sides they are 4 and 4. But in some occasion they may be, one of them may be absent, so don't get into these minutiae things. So my dorsal interossei, they were shown, you can match the color. And I use the word DAB, D-A-B. So dorsal, D for dorsal and A-B for abduction. So my dorsal interossei are designed for bringing abduction within my digits. And then you can see that now I'm using, because I cannot twist the hand, so I'm showing you 3. Fourth one I cannot show you. These are my palmar interossei. And then I'm using a word pad. P for palmar and AD for adduction. So palmar interossei are meant for adduction and dorsal interossei are meant for abduction. And now look at on the radial side, we have the radial artery, and then look at it, it perforate my first dorsal interossei to reach to the palmar surface. This radial artery, first it was located, it moved to the as the content of my anatomical snuff box, and then it pierces this muscle, and it also pierces something more here that we'll be looking at shortly. So after piercing this dorsal interossei, it has reached to the palmar aspect of my hand, and then it gives a branch which supplies my first digit, and this branch is named very specific. We call it principus pollicis artery. The word principus means principal, pollicis for my first digit, and for that. So the artery who supplies my first digit is called principus pollicis artery. And then you can see that one of the component from my same radial artery, it's going to supply the radial side of my index finger, so we call it radialis indicis. And then now my radial artery, it arches over to meet the ulnar artery on the other side, and it goes transversely. The level where it goes, I'll be explaining in one of the upcoming slide what is the level of this location, where we can locate this deep palmar arch. And you can see the ulnar artery has come in the picture to complete this arching pattern. This is my deep palmar arch which has been formed, and primarily who contributes here? The radial artery. You can say, oh, the ulnar artery is also contributing, but the main supply is from the radial artery. Now look at it, the radial artery is being branched, and even you can see that the ulnar artery, radial is branched, ulnar is branched. And then this is my ulnar artery, and look at it, from my deep palmar arch we have these metacarpal branches, and they are on the palmar side, so we call them palmar metacarpal arteries. And look, this is one of the intrinsic muscle which is very different, only one. For my thumb, we learn about thumb has this abductor, this flexor, this extensor, but we didn't talk about any adductor. So this is the only adductor for my first digit, and we call it adductor pollicis. This is a very unique muscle. It is a muscle for the thumb, but its nerve supply is not coming from the median nerve, it is coming from ulnar nerve most of the cases. And this muscle has two parts, two heads, and you are looking at the transverse component and you are looking at the oblique component. Are we good? And now my radial artery, when I told you it runs in the floor of my, as a content of my anatomical snuff box, it pierces first dorsal interossei, it also pierces the transverse head of my adductor pollicis muscle to complete its journey to meet its counterpart, that is the ulnar artery. And now the ulnar nerve is shown in the picture. On the ulnar side, it's a deep branch. So I'll be using different color coding for showing you the ulnar nerve, its deep and the superficial branch. Remember, the ulnar nerve is the main nerve of a hand. So a lot of discussion will be today regarding this ulnar nerve and how and where it supplies. So its deep branch continues, kind of an arch, and it's going to supply, and look at it, its superficial branch. I'm giving it a different darker color, and they can be differentiated from each other. So now superficial branch, you can see the color difference. And now look at my deep branch. From my deep branch of ulnar nerve, a component supplies a muscular branch. It supplies the two heads of my adductor pollicis muscle, and it's not only supplying here, it also goes both of my dorsal and the palmar interossei muscles. And you can see that I use this color for showing you the dorsal interossei, and this pink color has been shown for the palmar interossei, and you can see very clearly deep muscular branches from where? From the deep branch of the ulnar nerve, they are innervating my adductor pollicis, my dorsal interossei, my palmar interossei, and it will also supply two of the lumbricals that is coming up. I'm not showing you at the moment. Now you can see that individual supply through individual muscular branch to each of my palmar interossei has been shown, and similar pattern goes for my dorsal interossei. I hope we are clear so far. Okay, now what is this? This is my flexor digitorum superficialis, and it's going to each digit. We have talked about it. And now we are looking at flexor pollicis longus tendon. And this is flexor digitorum profundus for each digit. Now we are looking at the extrinsic tendons. And what is this worm-like structure which has just emerged? That is my lumbrical, my first lumbrical, my second lumbrical. They are located on the tendons of my, they are coming from the tendons of my flexor digitorum profundus, and they are going to the dorsal digital expansion. And you remember the nerve supply of my flexor digitorum profundus, the tendon which goes to the part of my flexor digitorum profundus whose tendons are going to my index and the middle finger. The nerve who was supplying this part of my flexor digitorum profundus, that nerve was median nerve. So these lumbricals who are attached to these tendons, they are also getting their nerve supply from the median nerve. And now look at it, they are coming by two on the digit 4 and digit 5. These are also my lumbricals, and these are my ulnar sided lumbricals, and their nerve supply will be from the ulnar nerve. So now we talked about this flexor synovial sheath. You are looking at it. They have shown in each, and we know about these annular and the cruciform pattern of the flexor fibrous flexor sheaths, how they have been fixed. Look at my tendon of my flexor pollicis longus is also enclosed in a sleeve, and that is also a flexor synovial sheath. They have their names. This one we call it, this is on the radial side. So this flexor synovial sheath is called as the radial bursa. And look at the pattern. Second, third and fourth, they are confined, but my pinky, it's connected with something at the bottom. If you remember when we were talking about the carpal tunnel syndrome, there we have shown the tendons, the organization of the tendons within the carpal tunnel, and you are shown 2 above, 2 middle and 4 below. And this place, this flexor synovial sheath where they all are blended, that is known as, it's on ulnar side, so we call it ulnar bursa. So you need to understand this concept. Now, this is my median nerve. Excellent. So median nerve branches. And then this is my flexor retinaculum. You may call it a ligament, so many names, volar and all that. And then now we are looking at the ulnar artery. That was its deep branch. This is its superficial branch. Remember, ulnar artery and ulnar nerve, their location is so superficial. At my wrist, a small sharp cut may cause significant damages to these structures. So if you encounter any person who has some cut, don't think it's a simple cut and cleaning the wound and putting 2 sutures will solve the problem. We need to check for the integrity of these nerves, that if there is any damage occurring to this nerve or then artery, if you don't do an earlier intervention, you might see someone loses function, and once a function is gone, then very difficult to regain that. So prevent it before it happens, and that is a rule for a good practice of medicine. So now ulnar artery superficial to the flexor retinaculum, it's going above, so it's not a content of my carpal tunnel. It's above, it's always superficial. And then now we can see the median nerve. When it's going, it's turning backwards. So anything turning backwards, we call it, there's a specific name, we call it a recurrent branch of my median nerve, and as I use a word in between in the brackets, that's a motor. So it has motor fiber. So it is meant to supply the muscles. And what muscles? The thenar eminence muscle. The thenar eminence muscles are located at the base of my first digit, my thumb. And then you can see, after giving this branch, guys, this median nerve, after giving this branch, all other branches which are coming from my median nerve, they all are sensory. They are not here to supply any of the muscle. Look at the digital branches going all across my digits, both the sides, radian and ulnar sides. So now, can I say 1, 2, 3.5 of my digits, they get their sensory supply through the cutaneous branches of my median nerve. You can see it happening here. Now I'm left with 1.5, and that we'll see who will supply there. So now look at the superficial branch. It's not the deep. Deep is this one. This is superficial. Superficial branch of my ulnar nerve. It supplies on the ulnar side of my pinky, radial side of my pinky, and ulnar side of my ring finger. So 1.5 digit. They are innervated by the sensory branch of my ulnar nerve, and this sensory branch of the ulnar nerve, you can see that when ulnar nerve was reaching near my wrist, it was splitting into a superficial and a deep branch. Deep branch is primarily muscular, and the superficial branch is primarily the sensory, and it is doing its job here. 1.5 digits have been innervated, the cutaneous supplies. Are we good? Now, another very important branch of median nerve which tells us a lot of the findings. This is going to the skin of the palm. We call it the palmar cutaneous branch coming from my median nerve. That's very important. Now, going back, let's put up the muscles here, And what muscle? First talk about the thenar. I'll not be showing you the full length of the muscle will be cut so you can see the underlying things. And their nerve supply is coming from the median nerve. And this is the first one. This is my first thenar eminence muscle. It is going to my thumb, so every last word will be the pollicis. And this is my opponent's pollicis muscle, and over above to it a muscle which has been cut in between just to see inside thing. That is what this is, my abductor pollicis brevis. It has been cut, and then we can see this flexor pollicis brevis muscle. So that has been cut. Now let's look at this recurrent branch of my median nerve, and you can see that it's supplying to all of them. Now look at the hypothenar. Guys, hypothenar, they are supplied by the ulnar nerve. Only you need to change. You need to replace this word pollicis with digiti minimi. Rest is the same. So no need to memorize a lot. This is my opponent's digiti minimi. This will be my abductor digiti minimi. And the last one will be my flexor digiti minimi. Are we good? And now we can see that through the deep branch, the muscular branches are coming to play to supply my opponents, my abductor, and my flexor digiti minimi muscle. We have already seen that ulnar nerve has supplied what? Adductor pollicis. Then it was supplying what? All the dorsal introccei, all the palmar introccei, the lumbricals of my fifth and fourth digit, and these hypothenar muscle. So this is the muscular distribution of my ulnar nerve within my hand, and the median nerve only supplying these thenar eminence muscles, and that's it. And the supply for my first and second lumbrical was driven from my flexor digitorum profundus because they are emerging from there. So median nerve has very limited supply, motor supply within the hand, but sensory there is a lot. I hope you can understand this difference. So now what are we making? You can see that the ulnar artery, here it has a big role. Previously we saw the radial, now this ulnar artery, and that is the main artery of my forearm as well as my hand, and you can see that it has a big contribution in making my superficial arch. And there you may see it may be complete or not complete, but this is my superficial arch, and primarily who's receiving blood, who's bringing blood here, the ulnar artery is the main source, and we are looking at the superficial palmar arch. Ultimately it gives my digital branches. Guys, on the way there will be so many names. You need to understand who and where it's been made and what are its main branches. On the way it gives so many branches, and all these arches are interconnected. We'll be watching them. So you can see that it's metacarpal branches, common, and then ultimately I'm going fast on that because what I have to show you, the common digital arteries, and they are going to each of my digits. I hope we are clear for that. We have talked about my first digit and half of my second digit. They were getting through the deeper arch, through arteria principis pollicis and arteria indicis, and the remaining are coming from my superficial arch. And then now the structure which is overriding, that is my palmar aponeurosis. Remember, my tendon of my flexor pollicis, palmaris longus muscle, that tendon, it fuses with my flexor retinaculum and it fuses with this palmar aponeurosis. 20%, 25% of the people, this tendon is not there. And the job of this tendon is just to stretch it a bit. Palmar aponeurosis is always there, but palmaris longus may be there, may not be there. Guys, another name might you'll read, that is palmaris brevis. I'm not mentioning about it here because it's not really clinically significant. So I hope we are fine. We have identified this triangular structure which increase the grip of my hand. And now this is the palmaris longus tendon. And now look at the palmar cutaneous branch of my median nerve, and if we have a sensation, we can tell that the median nerve is not damaged within the carpal tunnel. It was not working before coming to the carpal tunnel. We have discussed this point. And look at from the ulnar nerve, we also have a sensory component which is supplying the medial side, the ulnar side of my palmar area, the cutaneous area. So now I'm removing these, and there you go. Everything is inside the skin. The hand has gone in its gloves, and the skin covers everything. And now let's look at the cutaneous innervation, and this pattern needs to be very clear for you. Guys, we have talked about it. Look at this. 1, 2, 3 and half. Who's this on the palmar view? Palmar surface. It's my median nerve. Sensory branch. This blue thing, 1 and half, is my ulnar nerve. And then this reddish brownish thing, that is my radial nerve. And now look at the dorsum. You can identify because of the nail has been shown here, and look at the pattern. This blue again for the ulnar, this is for the radial, and look at these, the tips. We have the median nerve come in play here. I hope we are fine with that. Guys, this is clinically important. And now this, just by touching at 3 locations, you can say the sensory branches of median, ulnar and radial are there or not there. So these nerves are functionally there or not there. These are called autonomous zone. So if I just look at these circles, if you just give any stimulus, pain, touch or any kind of feeling, if that is valid, that means median nerve is working perfectly. And then at the pinky, in these precise places, these are the autonomous zone. So you are checking at the ulnar nerve, and then at the dorsum, you are checking at the radial nerve. I hope you will understand this. Guys, this is a clinically relevant point when you will be visiting your patients in the hospital, in the units. You will be asked to do this a lot, so you need to be practicing it a lot, because it is very instrumental and it's really helpful, and you are expected to be good with this concept. Now let's come to the arteries. We have talked about the formation of superficial and deep palmar arches. So this image is showing you, look at the finger pulp, look at the complex which has been created by the union of these 2 digital arteries. Remember, for each digit we have 2 parallel arteries along with the 2 parallel cutaneous nerves, so it runs. So if we have to work at the nail bed, we can just anesthetize the nerve here, we can block the nerve here, and we can do a surgery and patient can see it, but there is no pain if you do in nice way. But don't inject your anesthetic element into an artery or a vein. You have to be very careful. So now let's label the things. Ulnar artery, we are good with that. Guys, this black line is really important. So that shows me the level of my superficial palmar arch. Look at it, web of my thumb. It corresponds to this place. So you can just identify. If we can tell you through a vignette that someone has a sharp cut here, and it corresponds to your first web space, web of your thumb. So that means we are very close to the superficial palmar arch. So we are talking about the injury to the superficial palmar arch. Let's say a knife goes here. So this knife is very much vulnerable to damage my superficial palmar arch. This has to be very clear. And then this is the radial artery and this radial arch or the deeper arch, and you can see. So what is the landmark? First finger breadth proximal to my superficial arch. So you just put a finger here, and the distance is, this distance is of a finger. If any injury which is a finger breadth below to my web of the thumb, that means I am talking about deep palmar arch. We are not saying injury has occurred to the deep arch or injury has occurred to the superficial arch. We'll give you these landmarks. Be careful, watch out. These points are really important. And patient will never tell you, doctor, I have damaged my superficial arch or deep arch. Only when you examine a patient, a cut injury which involves the palmar surface of your hand. So you have to be connected with these anatomical landmarks, and that is really instrumental and helpful for your understanding. So these are the levels of my superficial and deep arches. You need to be very careful with this concept. These are the further labels. We have talked about them. Now this is something new, we didn't talk about it. This is on the dorsal side, and this is my dorsal palmar arch, and we'll be looking at it in a short while. So now you can see that all of them are interconnected. That's why my hand is so richly supplied. these are tiny arteries, but a small cut, it bleeds significantly. Now look at it. We are good with these. So now what we are using, this is my deep palmar arch, superficial palmar arch, and this is my dorsal carpal arch. I will not say palmar arch because that is on the dorsal side and it's closely associated to my carpal bones. So it is proximal. Look, this is distal, this is proximal, this is, so everything become distal and proximal to each other. Learn this concept. So now look at, from my deep branch, a digital artery goes through, and after that it's no more a branch from my deep arch because they join, and primarily we know that it's coming from the superficial arch, and then you can see that from the dorsal arch. Basically I'm trying to show you how they are connected. So everything is connected at different location. So when a blood reaches here, when a cut happens at the tip of your finger, it bleeds a lot. The reason, all of three are contributing well. So my ulnar, radial, everything is contributing, and someone bleeds a lot. And these are the joints, these are the articular branches which are going to these joints. So now let's look at, there is a small exercise which will help us understand where is the precision, where is the power type of activities occurring. So now there you can see on this image, you are looking from A to J. These are the different actions, movements has been shown you there. So I'm just quickly labeling over. So now this is the power, precision. You are so precise because if you are powerful, if you bring a power here, what happened? This egg might break if your power is really strong. And here you need power and precision both, because when you are holding a ball, you are throwing it. That is a power. But the rotation, the movements of your finger will give it a swing. Those who are pros, they understand what is this swing and how you can dodge the player to whom you are pitching. And look, in these, the modified of different precision, different level of precision, a fine to a crude type of precision from image D to image F. And look at it. There is something more unique. What is this? Precision or a power? This is power key pinch. You are doing it. Now look at the bottom. These images are little different. So we can see the precise, prehension, and different type of things. So you are more precise. So you are coming up with different activities. But look at this formation, guys. This is important, and that tells us a lot. And we'll be talking about these in our upcoming session. Look at this, how we are hooking a bag, and this is a hook grip. Again, it's more of a modification of precision. These are not power, but these are modified precisions. Now, coming to a combination of power and precision. Now we can see at one place there is a precision, there is a power. There is a precision, there is a power. There is a precision, there is a power. So how is happening? You can see that here is a power, here is a precision. Power, precision, power, precision. Now look at different diseases. Look at this hand. What is this happening? This is a specific name. We call it Dupuytren's contracture only. Just you should know it. This is called Dupuytren's contracture. There are nodules and cords and all that. You'll be learning these things in future, not today. So no, don't spend a lot of time how and what is the underlying mechanisms, but this is good to know. You can mix it very easily with ulnar claw. And then look at this hand, very classic, and I'm sure you have seen so many elderly people having a hand like that. If not, just pay attention to this. And this is a hand of rheumatoid arthritis. So the involvement of rheumatoid arthritis is a disease where there is an involvement of small joints. Osteoarthritis is a disease where we have involvement of the large joints. And rheumatoid arthritis, it affects symmetrically both the sides. And osteoarthritis, mostly it's an isolated. Let's say someone has a pain in his left knee or right knee, left hip or right hip. So this is how it goes. But I'm not talking in detail about these. But remember, what is the message? Carry home. Prevent something before it happens. So prevention is better than cure. If you see someone is adopting these kind of changes, and if you don't intervene in time and you let it go, then once this change becomes permanent, then it's very difficult. You need a lot of surgeries to revert, to go back to the norm, and that is quite a challenging practice. I hope we are fine. I have tried to go over with the main basic concepts. I have touched only the functional components of the hand. I have not gone in details of the minutia details. If you are interested, you can do that, but you are highly recommended to stick to these functional things, the structural, their organization, and the nerves, how they are and where they are supplying, what are their locations, the precise actions of these muscles. Be good with the action of the lumbricals, actions of these flexor digitorum superficialis, profundus, how a fist is formed, who is involved in all that. So you should be knowing, you are expected to be knowing a functional hand, not only details of a hand, and that needs a lot of time. What is expected from you? You should be knowing this functional description. If you want details, inshallah, for future, those who want to pursue their career as hand surgeon and vice versa, so more reading is highly recommended at that time. So guys, this slide gives you some idea where and what is happening. I hope you can read through. This has been provided. Thank you very much. I know it was a very heavy lecture, but this is the most important content which has been delivered and discussed with you.